Hi, my name is Maria Yeager. I'm the founder of Adenomyosis Fighters. I have with me today Dr. Eisen Liang, and I'm just so excited to be talking to you today. He is the author of this book. It's called Could It Be Adenomyosis? Um, and I've read this book, and it's just loaded with such helpful information regarding the use of uterine artery embolization, also called UAE, for adenomyosis. Um, so, Dr. Liang, would you just kind of give an overview of how uterine artery embolization can be effective for adenomyosis treatment, in particular, the difference between focal and diffuse?
Right, okay. So UAE stands for uterine artery embolization. It is a local anesthetic procedure done by an interventional radiologist in a angiographic suite. And so because we don't involve cutting, we use a natural pathway, which is a uterine artery. And so it's a very minimally invasive procedures. Cardiologists putting in stents in the heart using the similar methods. So instead of in the past, we had to do bypass surgery. We have to open people's chest and do the bypass surgery. Nowadays, we just go through the natural pathway into the coronary artery to deploy the stent. And here, of course, we're not opening up an artery, we're blocking an artery. I just see if I can share the screen so I can share and show you. Can you see my screen now, Maria?
Yes, yes.
Okay, so we're talking about uterine artery embolization here. So basically, as you can see the diagram there. We use ultrasound guidance, local anesthetics, so get a small tube. The size of the tube is like the silver of the ball pen, right? It's quite small, and we navigate the catheter into the uterine artery. And once we reach the artery, and we're going to inject some particles in, that's carried by blood flow into the uterus and to shut down the blood supply. And I'm just going to go in and to show you how it works. So as you can see, even though it's not a selective, it is not a selective embolization. Is what we call global embolization. That means you blocked the left and the right uterine artery. So the question is, how come? And the adenomyosis tissue is there. This is a large focal adenomyosis. Is that yet the normal part of the uterus is not harmed? And that is because during pregnancy, as you know, the uterus enlarges enormously, carries that with 40 times increase in blood flow, so that and there's a lot of vessels that's dormant normally. So during pregnancy, when the need is increased, they open up. And once the baby is born, the blood vessels shut down. So a lot of blood vessels are there, they're not flowing. So even though some of the particles end up in the normal part of the uterus, it doesn't matter. And but the adenomyotic tissue is different. They don't have spare vessels. So once you get these particles in, the blood vessels are shut down permanently, so tissue cannot live without blood supply, and they die and they shrink. But the normal part of the uterus is not harmed. So therefore, for adenomyosis, doesn't matter if it is diffuse or focal, and doesn't matter whether there's any fibroid in it as well. Any abnormal tissue within the uterus will be treated in one go. And so that's the beauty about this procedure.
That's just absolutely amazing. That's amazing. I had a couple questions. First of all, the blood vessels that open up, like you said, to feed the normal part of the uterus, do they stay opened up, or do they eventually shrink back?
So, okay, as you can see the illustration here, some particles will end up in the normal part of the uterus.
Yes.
But there are many, many more dormant collateral vessels that's not flowing. So they self-protected in a way. So after we block the normal part of the uterus is not going to like it. So the patient might feel pain overnight. That's why they need to stay overnight on pain relief medications. And And so the uterus is able to recruit the dormant collateral vessels to
Okay.
protect itself. So overnight, other vessel will open up and to nourish the uterus and to regain the blood supply. And that's why you can see the normal part of the uterus remains viable, as seen by this contrast enhancement here. And
Okay.
yet the adenomyotic tissue will be dead.
That's just incredible.
Yeah, you can't do this to any other organ. The uterus is unique in the body
Okay.
because it's
Because of
got this
those.
rich, very rich collateral blood supply.
Okay.
So it doesn't matter you block a few normal ones because there are many others that the uterus can reopen and recruit and the collateral vessels. The vessels are there, that normally just they're not flowing. That's why they're protected from the particle.
Oh, I see.
Yeah.
This picture that you have down here, I'm interested. Um, I definitely, I mean, I've looked at a lot of these. I'm not a doctor, but I've looked at a lot of the pictures and I think I know what
Yeah.
I'm looking at.
Yeah.
But it still seems like even though I can see where the scar tissue is on the after the UAE, but it
Yeah.
still looks like the uterus itself is bigger than normal.
Yeah,
Is
there's
that true?
different, obviously adenomyosis is just a spectrum of disease. And so there are so many different kinds of adenomyosis. I'm just going to show you a illustration to show you the point.
Okay.
And so you can see this is a proposed, sadly, even to date, we still haven't got an agreed classification of adenomyosis. We haven't had a agreed and staging for adenomyosis yet. But this is proposed by somebody, and so that's a superficial type, and that's a diffuse, a deeper one. This is a focal one, and this is the Japanese has used to call this called juvenile cystic adenomyosis, but we find this in older women as well. Others can look like fibroids, is either with protruding in the cavity on the outside. And when they're really on the outside, they merges with what they call the deep-seated endometriosis. So it's a spectrum of disease. It's not a single disease. Now, beauty of UAE is doesn't matter where you have the adeno, as long as the adeno draws its blood supply from the two uterine arteries, they get treated. Okay, yeah. So I'll show you some example here. So we go down to case studies here under adenomyosis. Oh, yeah, all right, case studies. And so the first one, as you can see, this is of course, all the illustrations are MRI. On MRI, the endometrium or the lining is very bright because it's rich in fluid, rich in protein, and therefore this is the two lining abutting each other. So that's a cavity, right?
Okay.
So the lining tissue, which is the endometrial tissue, should not be in the wall. If it's gone into the wall, by definition, it is adenomyosis. Adeno means gland, myosis means muscle, so the gland has gone into the muscle. So you got these more normal glands in the muscle, that's adenomyosis. And the second part of the pathology is the reactive changes. So because you have inflammation, abnormal tissue there, the muscle react to that by thickening. And that's a reactive muscle hyperplasia or hypertrophy, meaning thickening. And that is the main cause of the uterine enlargement. You can see this thickening of the junctional zone here. Now, after embolization, because the tissue is gone, so you can see almost normalization of the junctional zone. You can see the disappearance of the ectopic endometrium there. So this is one form of adenomyosis that's before and after UAE treatment.
Okay.
The second form here, quite often, actually, this is more often, is that on the MRI, all we can see is the thickening of the junctional zone. We only see the secondary changes. We don't see the bright glands anymore, but that doesn't mean that the patient doesn't have severe symptoms. She had just severe symptoms like, a lot of the other women. And even though, this case 1 and case 2 were typically missed by ultrasound because the changes are so subtle.
Okay.
Both
Okay.
women, in both cases, they missed by ultrasound. And so we picked them up on MRI. You have to excuse them because it's not someone's made a mistake, someone missed it. It's just a limitation of the ultrasound technology. It's very hard for them to pick this up.
I see.
Okay, but on the MRI, you can see this is
Oh,
after
yeah.
treatment. You can see the beautiful normal junctional zone there. Yeah, and that's
I
the
see.
thickening there.
It's so clear to me.
Yes, yes, I make it bigger.
Okay.
Even better. So
Okay.
sorry, I should have
No,
done
no,
that
no.
before. So that's the case before. We were showing the abnormal glandular tissue, and
Yes.
that's normal junctional zone after UAE. And
Yeah.
here we only see the junctional zone thickening here, and this is after UAE. Now I'll show you two more examples here. Case
Okay.
3. Now this is a case. It was referred to me. Say, please embolize this fibroid. This lady's got fibroid. Can you treat her? I
Okay.
look at the ultrasound scan, I was squinting my eyes. I said, I'm not sure I'm seeing a fibroid. So she had an MRI. This is an MRI. So they mistaken this as fibroid because it's a focal lesion. So anything that's focal in the uterus, ultrasound tend to call them fibroid. But this is not fibroid. How do I know? Number one, it doesn't have a distinct border. Fibroid is like a lump. This one doesn't quite look like a lump. It merges with the junctional zone there. And also the giveaway is the bright signal there. Can you see that bright signal?
Yes, I do.
Yeah. So that bright signal is a giveaway. So this is an adenomyoma. It's a focal adenomyoma, right? Well, focal adenomyosis. So she didn't have a fibroid to start with. And this is after embolization. What happened to this focal adenomyoma? It becomes a scar tissue, just like fibroid.
And it looks smaller. Does it shrink too?
Oh, yeah. It definitely has shrunken. And it's just a scar tissue. So you can only get smaller because you can't revitalize the scar tissue.
Okay.
Okay, you can't revitalize a scar tissue. It's inverted comma, it's dead tissue, but it's part of us. We carry a lot of non-viable tissue with us. All our hairs, our skin, our nails, they're not living tissues. They are already sort of dead tissue, but they're attached to us. It is okay, it's fine, and they're not going to do any harm there.
Okay, that's good to know.
Yeah, that's one more case here. This is quite a tragic story that she for more than 10 years, she's been told, you just have a fibroid, don't worry, 70% of women will have a fibroid. She tried to get pregnant, she was having multiple IVF cycles. And at the end, and she said, no, I'm giving up. She's 45 years of age. And I just want my life back. They said, all right. So, but she doesn't want to have hysterectomy because she hasn't had children. So psychologically, she felt, she wants to feel attached to her uterus. So she was sent to me, said, can you please treat her fibroid? And again, the same thing. This is not fibroid. And this is adenomyosis. How do I know that? Number one is an infiltrative lesion. It's not a very sharply defined lesion. I'll show you some example of fibroid that look different. Okay. Number two, the giveaway is this bright signal. These bright signals like the signal from the endometrium, which is bright. So these are the endometrial glands.
Oh, that makes sense. I get it now. Yeah. Oh.
Yeah. All right. So after treatment, this is a focal lesion. So the whole thing is kind of dead. All right. Okay. So the uterus, what you can see is that the uterus is not harmed. The main thing is the uterus is not harmed. The normal myometrium still enhances with contrast. And this one is, with time, it's going to get smaller and smaller.
Okay, it will shrink. Right? Okay.
So yeah, so it might shed off a little bit with each period, and so less and less. And but the main thing is that the aim of the treatment is to treat the two major symptoms of adenomyosis. One is the heavy menstrual bleeding. The second one is severe period pain. And for both symptoms, as well as premenstrual bloatings, and UAE is very, very effective. We have 90% overall success rate, 90%.
I saw that in the book. I mean, that's impressive. Yeah. That's really impressive.
Yeah, I mean, we found this accidentally. And we know that this, I mean, I just show you because we talking about UAE for adeno is not complete without talking about UAE for fibroid.
Okay.
Okay, because
Okay.
I just want to show you what fibroid. See, fibroid MRI is distinctively different from
Oh,
adenomyosis.
wow.
You can see the very sharp margin. Yeah.
Yes. Yes.
And after embolization, it can be somewhat similar because it's just like a scar tissue there,
Scar
right?
tissue. Okay.
Yeah, and see there's another fibroid here. This is what we call the submucosal fibroid. It's poking in the cavity, and after embolization, it's shrunken down to a tiny nodule.
Oh my goodness, that's amazing.
And
Wow.
this is, if you that's amazing, this is even more amazing. She's got a
Okay.
500 mil uterus. Can you see that?
Yes.
You can
That's
see her
huge.
bulging tummy there.
Yeah.
Yeah, so it's not hard to imagine that she have a lot of bladder symptoms. Well, guess what? The poor bladder sits here,
Okay.
and this large rock sitting on top of the bladder.
Okay.
When she trying to fill up the bladder, normally you just push the uterus up, but here you're against the spine. There's no
Oh,
more space.
she must have been in horrible pain.
And it's the bladder symptoms, and also
Yeah.
look pregnant. She looks like 18-week pregnant, so it's
Oh,
unbearable.
goodness.
So
Wow.
after embolization, you can see the significant shrinkage of fibroid
Oh,
from
yeah.
500 mil to 200 mil. Now you can see she's had a flat tummy now.
That's
Okay.
incredible.
Yeah.
Okay.
And the important thing I want to illustrate here, just like UAE for adeno, the uterus did not seem to be harmed. The normal part of the uterus is this bit here. It
Okay.
was stretched before, and this is after. So the fibroid is dead. The myometrium of the uterus is not dead.
I
Right?
see. Yes.
The beauty about UAE, UFE so it doesn't matter what you have in the uterus. So like this lady got more than 20 fibroids in the uterus.
Uh-huh.
It doesn't matter. Each single one of them get treated.
My goodness gracious.
Yeah, if she has adeno inside as well, it doesn't matter because adeno get treated. The
Okay.
reason I mentioned fibroid is that we accidentally, when we were auditing our result of for fibroembolization around year 2010, we found that about 29% of the patients also have adeno as well. Then we said, oh, that's interesting. Let's see whether these procedures also effective for adeno. And to our surprise, it was highly effective. All right.
Wow.
And therefore, we said, all right, then we should probably look at this more systematically. So I'm going down to the doctor's resources. So, so we find out, so in this paper here, 2012, we find that about 29% of our patients also have adenomyosis, and the success rate for adenomyosis was pretty high. We thought that was interesting. So, and then we did a formal study for adenomyosis, and our first paper was published in 2018. And it's this paper here. And I had a Canadian overseas medical student, Maxim. He's from Toronto. He came over and he was interested in what we do. So, so he helped me to get the data together. So we published this paper that remains the largest case series in English publication in the world.
Oh, wow.
Then we were able to achieve 90% overall patient satisfaction rate. Now, for patient success rate, what we define that as the period need to be back to normal or lighter than normal. Okay. And their period pain must be significantly improved so that they're happy or very happy with the outcome.
Okay.
The pain score drop in this group was significant. On average, they all have 7.5 out of 10 pain. Of course, some people have more, some people have less. On average, 7.5. 7.5 is quite significant. Most people can't get by without any analgesic for 7.5. 10 is excruciating childbirth, fracture kind of pain. 0 is no pain. So on that scale, this group of women have pain scale of 7.5, right? And after treatment, the average is 1.3.
That's a huge drop.
It is a huge drop.
Wow.
So, and the other way to look at this is that um, all these women have severe enough symptoms. They have failed conservative therapy, meaning that they fail medical therapy, they fail Mirena. Some of them have failed ablation as well.
Okay.
Okay. In the past, as we all know, the only other option is hysterectomy.
Yeah.
Okay. So then we look at the hysterectomy rate of these patients. Even though I say 90% success rate, the other 5% we manage with additional medical therapy, meaning that they're not outright successful, meaning that they say, oh, yeah, it is better, but it's still somewhat heavy. It's still my heaviness still not back to normal yet. Then we say, all right, why don't we try a bit of transamic exit? Why don't we add a bit of non-steroidal? And why don't we put the Mirena back in again? It didn't work before, and let's see whether it works now. Now that saved the other 5%.
Oh, okay.
Okay, so we end up having only 5% of the patient having hysterectomy. So the other way to look at this is all these women were lined up for hysterectomy, and we were able to save 95 out of 100 women
That is,
otherwise who would have gone through hysterectomy.
wow.